Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Ipsen.
Good morning, Mr. and Mrs. Silva. How has Leah been doing since our last appointment? How are you both managing?
Doctor, we're at our breaking point. Leah barely sleeps maybe an hour or two at a time. She's constantly fussy and she scratches her skin whenever we're not holding her hands.
We take turns staying up with her through the night. We've tried everything, mittens, swaddling, but she still manages to scratch. We often find bloodstains on her sheets from the open scratches. Look at her chest and arms.
I can see the redness on her skin and some excoriations. The pruritus is clearly severe.
We're exhausted. I had to stop breastfeeding because I couldn't manage the sleep deprivation. My husband has been taking time off work because I can't just do this alone. I'm just so worn out. And I'm very concerned about Leah's development. Will this affect her in any way at such a young and tender age?
Your concerns are completely valid, Mrs. Silva. Sleep deprivation at this age can affect not just Leah's comfort, but potentially her growth and development. Let's review her current treatment. She's on UCA and rifampicin, correct?
Yes, but we have not noticed any significant improvement in her symptoms. She is still miserable. Doctor, we have to ask, what does this mean for Leah's future? Given how severe her symptoms are at only 6 months old, what should we expect? If medicine doesn't work, does this mean we are looking at liver transplantation?
Yes, please be honest with us. What's the long-term outlook?
I appreciate you asking the difficult questions. Alagille syndrome is indeed a progressive liver condition. While the severe pruritus is the most debilitating symptom right now, we must also monitor liver health for possible complications that may arise. And yes, in some cases, the need for liver transplantation can emerge in early childhood. It's precisely why finding effective symptom control and the right treatment plan is so critical for your daughter.
There must be something else that we can try. She's just a baby. She should be reaching her milestones, not suffering like this. Are there any other options?
There are, and I'm glad you asked. Let me discuss some newer treatment approaches that may work better for Leah's symptoms.
Hello, my name is Giuseppe Indolfi. I am Associate Professor of Pediatrics at University of Florence and I'm a clinical active hepatologist working at the Mayo Children's Hospital of Florence. Welcome to this program titled Navigating the Management of Alagille Syndrome using Ileal Bile Acid Transporter Inhibitors. Today we will talk about Alagille Syndrome. We have recently learned about the story of Leo's. Alagille syndrome is a multisystemic disease, it's a complex disease. Liver, of course, is one of the target organs, and it's an important organ for the prognosis of patients with Alagille syndrome. But of course, many other organs can be involved in the syndrome. So we can suspect the diagnosis based on the fascias of the patients. Cardiac involvement is extremely important because this can impact as well the long-term prognosis of the syndrome. And of course, there are possibilities of having skeletal abnormalities and kidney involvement. In terms of liver disease associated with Alagille syndrome, we know that patients with Alagille syndrome typically present in the first year of life, and more commonly soon after birth with cholestasis. One of the clinical signs of cholestasis is the presence of pruritus. Pruritus can be severe, can appear during the first few months of life, and can be accompanied together with xanthoma that usually appears at a later stage in the course of the disease. Many children will progress, and liver disease can be as severe to require liver transplantation. So these children will have end-stage liver disease, and at some point they will get transplanted. We learned and we have just heard about the story of Leos. We have seen how devastating, how debilitating can be itching with all the scratch signs that can present on the skin of the patients with Alagille syndrome. Children are unable to sleep, and together to the children, the entire family, as we have just heard, can actually be involved in the management of pruritus. And of course, this is a family disease. The quality of life of the entire family is affected by the presence of severe pruritus. If you want to know something else on the natural history of the Alagille syndrome, important information has been provided by the GALA study. The GALA study is a multi-center retrospective study involving almost 1,500 children with confirmed Alagille syndrome. One of the major information that we get from the GALA study is that the likelihood of having a liver transplantation in the first 18 years of life is quite high. The survival rate without liver transplant at 18 years of age is around 40%, meaning that 60% of the children will present with advanced liver disease and will require liver transplantation by the age of 18. Medications that have been used for treatment of Alagille syndrome historically have been UDCA and rifampicin. We have heard the story of Leos. These drugs were not effective in controlling pruritus. Other drugs are available, cholestyramine, for example, and other drugs that are less commonly used, such as ondansetron, sertraline, and naltrexone. The common important aspect of these drugs is that we have always been using these drugs over years, but there is no clear evidence supporting their efficacy and safety in patients with Alagille syndrome. But now let's go back to Mr. and Mrs. Silva to see if Leo's laboratory results can tell us more.
Looking at Leah's labs, her serum bile acid levels are very high, well above normal. Leah is also experiencing severe pruritus.
You mentioned other options. What can we try to avoid surgery or transplantation?
Yes, there is a newer option called IBAT inhibitors, short for ileal bile acid transporter inhibitors. IBAT inhibitors block the protein that recycles bile acids back into the body. This lowers the bile acid buildup and should help reduce Leah's pruritus.
And does this work in young children like Leah?
Studies in pediatric patients with Alagille syndrome have shown significant improvements in pruritus, sleep quality, and overall quality of life.
But is this safe for someone only 6 months old?
Excellent question. These medications have been studied specifically in infants with Alagille syndrome. Leah meets the key criteria. She has her native liver intact, persistent severe pruritus despite treatment, and elevated bile acids. All these factors make her an appropriate candidate.
Would this help protect her liver from needing transplantation?
That's precisely the goal. By reducing bile acid burden, we can be successful in improving her pruritus and potentially her long-term liver health. There are data supporting this, showing that these medications can prevent the progression of liver disease and the possible need for liver transplantation.
When would we see improvement?
Most families notice improvement within 1 to 4 weeks, with full effect by 3 to 6 months. The most common side effect is diarrhea, which usually improves over time. You can contact me immediately if it becomes severe or if you see any yellowing of her skin.
We should try this. Anything that might help Leah sleep and stop the scratching. We just want to see her live a normal, happy life.
Yes. Let's proceed. When can we start?
I'll send the prescription today. Start tomorrow morning. We'll schedule your 3-week follow-up to make sure Leah is tolerating the medication. Then I'd like to see her every 2 to 3 months going forward. In the meantime, please call my office if you have any concerns.
Thank you, doctor.
What an interesting discussion. The doctors and Leo's parents are evaluating the possibility of starting Leo's on IBAT inhibitors. Let's try to understand something more. What are the goals of treatment with IBAT inhibitors? According to the results of the study, one of the major aims of treatment with IBAT inhibitors is to control pruritus through the reduction in serum bile acid levels. We know as well that the secondary outcome were improving the growth of the patient and improving the quality of life of patients and their family. IBAT inhibitors are drugs that are able to interact with the enterohepatic circulation of bile acids. Bile acids are produced by the liver, are secreted inside the bowel where they do their action, and then they are reabsorbed in the distal ileum by the enterocyte. Well, IBAT inhibitors are able to interact and block the reuptake of the bile acids in the ileum, so reducing the serum bile acid levels. 2 drugs so far have been approved. The first one is maralixibat, and the second one is odevixibat. Maralixibat has been approved by EMA for treatment of cholestatic pruritus by the age of 2 months for patients with Alagille syndrome. Odevixibat has been approved for the same indication in patients aged 6 months and older. Is Leo the ideal candidate for treatment with IBAT inhibitors? I would probably say yes, because Leo has been diagnosed with Alagille syndrome, has not been transplanted, is presenting with severe pruritus, has already been on traditional treatment, the standard of care, without any real impact in terms of controlling pruritus, and has high serum bile acids. Leo is actually fulfilling all the indications that have been provided by FDA and EMA. And again, we already commented on it. IBAT inhibitors are the only drugs that have been evaluated in terms of safety and efficacy in patients with Alagille syndrome. The safety and efficacy of odevixibat for treatment of patients with Alagille syndrome has been evaluated in the so-called ASSER trial, where it was demonstrated that the use of odevixibat was able to reduce pruritus, to reduce serum bile acid levels, improve the sleep, the quality of life, and the growth of the patients treated. Maralixibat has been evaluated in patients with Alagille syndrome with the ICONIC trial. And again, in this trial, it was clearly demonstrated that the use of maralixibat was able to reduce pruritus, serum bile acid levels, improve the sleep, the quality of life, and the growth of patients with Alagille syndrome. The evaluation of pruritus and the impact of treatment on pruritus was evaluated using some validated scores that nowadays are used in the clinical practice. We can generally comment that there is no direct correlation between pruritus and serum bile acid concentration, but the reductions in pruritus score and in serum bile acid levels were going in the same direction in both trials. Another important information that I can provide you with is the possible impact on the use of maralixibat in the long-term survival of patients with Alagille syndrome. Patients treated with maralixibat were actually compared with similar patients selected from the GALA cohort. And as you can see, there is a clear impact in terms of long-term native liver survival in patients who were treated with maralixibat as compared to those who were actually included in the GALA cohort and did not receive any treatment. Important information will come and will add to our knowledge from long-term real-life studies and data collection on the long-term impact of treatment with IBAT inhibitors in patients with Alagille syndrome. But now let's go back to Leo and let's see how he's doing at his next visit after starting treatment with IBAT inhibitors.
Good morning. Leah looks much more comfortable. How have these past 3 months been?
Doctor, it's been transformative. Leah is sleeping 5 to 6 hour stretches now, and the scratching has decreased dramatically.
We're sleeping through the night for the first time since she was born. Look at her skin. It's almost completely healed. She's sitting up, babbling more. It's like we have our baby back.
This is exactly the response we hope to see. The scratches and excoriations have healed nicely. I don't see any new exposed skin. The irritation is no longer visible. Any challenges or side effects with the medication?
She's had loose stools, sometimes diarrhea. Is that normal?
Very common. When we block bile acid reabsorption, more of it is able to reach the colon, causing softer stools. Most infants tolerate this well, and it often improves over time.
It's been manageable, maybe 2 to 3 episodes during the first 2 weeks of treatment. Nothing compared to the constant scratching and fuzziness she experienced before treatment. If her diarrhea returns, can we adjust the medication if needed?
Yes, but because it is rare that diarrhea returns once it resolves, a dose adjustment may not be necessary. However, we will continue to monitor Leah and determine if a change in her dose could provide additional benefit in reducing pruritus and maintaining her liver health over time. Right now, based on Leah's labs, she appears to be showing improvement. Her bilirubin is stable, liver enzyme levels improved, and bile acids decreased significantly. These are all very positive signs, indicating that Leah is benefiting from this medicine.
How long will she need to be on this medication?
IBAT inhibitors are long-term management, not a short-term fix. As long as Leah continues doing good and tolerates it well, we'll continue. This protects her liver health as she grows, so it's important to keep her on this medication.
What should we watch for at home?
Watch for return of significant scratching, any yellowing of skin or eyes, or severe persistent diarrhea with dehydration. Call immediately if you see these. We'll monitor her every 3 months, checking pruritus scales, bile acids, liver tests, and growth parameters. If we see waning response or rising bilirubin, we'll adjust the dose.
And her long-term liver outlook?
Our goal is to maintain Leah's native liver as long as possible. By reducing bile acid burden now with IBAT therapy, we're giving her the best chance for preserving liver function long term.
Thank you, doctor.
Leo responded very well to treatment with IBAT inhibitors. And from now on, how can we track the response to IBAT inhibitors? Checking for pruritus is very easy. We can use the scores, and of course, parents will provide us with important information on the control of pruritus. It is very uncommon to have a loss of efficacy. And loss of efficacy can be easily detected when you see the patient and you discover that there is a new or worsening jaundice. When you check the blood test and you see that there is a worsening in liver function test, or when there is a worsening in cholestatic pruritus. And of course, the parents will be very sensitive in referring this worsening. Overall, I can tell you that IBAT inhibitors are usually very safe drugs. They are minimally absorbed at the gastrointestinal level. The rate of adverse event described in the trials is quite low. Diarrhea and abdominal pain have been the most frequent adverse events reported in the trials. And it is important as well to say that diarrhea and abdominal pain are usually mild and reversible. We need a strategy to manage the side effects of IBAT inhibitors. It is important to know that diarrhea and abdominal pain usually occur during the early phase of treatment. Then you can control the possible development of these adverse events by dose titration to improve the tolerability of the drug. And then when the diarrhea settles, for example, you can go back to the original dose if there is a clinical need. This is more or less what happened with Leo, who presented with mild symptoms with mild diarrhea. Well, it is important to monitor this diarrhea, and if the diarrhea becomes important, then of course the dose can be reduced. One of the possible side effects is the appearance of raised transaminases levels and less frequently of bilirubin. Of course, again, you can try to control this possible side effect by reducing the dose of the drugs. Well, IBAT inhibitors are important drugs. They interact with a single receptor. We know that we are only at the very start of this long story. There are future therapeutic options that probably will be based on combining drugs with different mechanisms of action. I think, for example, to farnesol X receptor agonists that can be used together with IBAT inhibitors to prevent the compensatory new bile acid synthesis induced by inhibiting IBAT receptor. Or, for example, the possible use of a cholestyramine together with IBAT inhibitors to counteract the complications related to the increased colonic bile acids. In terms of treatment discontinuation, this is a possibility that is very rare and should be considered when there is a non-response, so no impact, no positive impact on pruritus or in reducing serum bile acid, when there are important adverse events that cannot be managed by dose reduction, of course, when there is need for liver transplantation. That is the only option in case of advanced irreversible liver failure. So in summary, IBAT inhibitors are very effective drugs to control pruritus and reduce serum bile acid and can improve the quality of life overall of the patients and of families. There are preliminary data showing that IBAT inhibitors treatment can improve the long-term liver outcome of patients with Alagille syndrome. But this information is coming mainly from comparison with historical cohorts. There are many questions that we need to address in the near future, how we can best predict response, and if and how and why there could be a loss of action for patients who are on treatment with IBAT inhibitors. There is the need of future studies to explore how we can maximize the efficacy of IBAT inhibitors through combination therapies. Thank you so much for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.